to the Lipoedema Podcast. We are your hosts, Shell
and Tiana and Nova. And today we have a very special guest. We have plastic surgeon, Associate Professor Thomas Lam from Sydney. Prof. Lam, thank you so much for joining us.
You're welcome. And lovely to join you.
Yes, so great having our surgeons on to talk about their different approaches to lipedema, because as I found out at the Lipoedema conference, when there was the panel discussion, you all operate so differently. And I love that.
That's right.
So before we get into everything, I'd really like to know how you came to learn of lipedema and when that was.
Well, it's a very interesting question. So I actually didn't know about it until I got involved with lymphedema surgery, which is different. And as you probably know, a lot of patients, a lipedema patient end up in a lymphedema clinic. And that's how I come across the condition myself, to be honest. And we started our first surgery in 2015, Macquarie University Hospital, really pretty much doing what we're doing for the lymphedema. And that's why our approach is a little bit different. Initially, we did try, and you would know, the water jet system, because everyone seems to be using it. But we tried it. We won't go into too much detail to turn you off, but we found that what we've been doing with the lymphedema, which we're familiar with, which is the Bronson technique, which we'll go into in a minute, that works just as well for us. So we don't have to change our method.
That's great.
And so we just continued it.
So you can use the same expertise you use for lymphedema in your lipedema patients.
That's right.
Excellent.
That's great, because as we know, because you all operate differently, you need to be comfortable with the methods that you're operating in, and it makes you better at when we're on the table. We need to be able to, you just got to
play into your strengths.
Totally.
Yeah.
Great.
Yeah, that's right.
Yeah. Thank you, Shirley, for saving me there.
And also, it's not just myself. We have a whole team looking after the patient. So the more familiar it is, the better, the more comfortable everyone is.
Yeah. And there's years of experience, like since you said 2015.
Yeah.
How long for lymphedema? So you said lipedema 2015.
So lymphedema started in 2012.
Okay.
Yeah.
Oh, so it wasn't long before you stumbled across lipedema. That's awesome.
Yeah.
Yeah, people just turn up in our clinic because they often are misdiagnosed as lymphedema.
Yeah.
And then so they come across, and then we help them realize that they're not. And then but we still pretty much do the same surgery.
Yeah.
Okay. And I'm curious about like the lymphedema and lipedema, because as you mentioned, that as we progress through the stages, there is elements of lymphedema. But in the earlier stages, so like stage 1 and 2 of lipedema, how often do they coincide with each other that you see?
Well, the early stages, they wouldn't coincide. Would be, I think, really advanced lipedema. You can then have some lymphedema components to it, but not the early stages.
Not the early stages. Okay, thank you for that. So in your practice, when you are dealing with a lipedema patient who has suggested that they might be interested in going for surgery, how would you determine them to be surgery ready?
Yeah, so we go through, I'm very blessed. We already had the clinic going with the lymphedema. So we have rehab specialists who are expert in both lymphedema and lipedema, which is Dr. Helen Mackey. And she would assess the patient, make sure that they haven't got any other medical condition, any other issues. We, in particular, often is in terms of managing their weight, diabetes, that type of situation. And we also, because it's an elective procedure, and it's now becoming formalized by the government, that we need to assess the patient if they had any body dysmorphic issues, any psychological issues. So our clinic can refer them to see dietitian, nutritionists, psychologists if necessary. So we assess them medically to be fit, then they can benefit from surgery. Then they talk to the therapist to get used to the idea of having some garment that they got to get used to. And then if they actually want to pursue surgery, because not everyone wants to have surgery, then they'll come and see me, and then we go through what surgery involved. And again, our surgical approach is a bit different from others because we come from the Bronson technique with the lymphedema, where we treat the whole leg at one stage.
Mm-hmm.
Quite often you find the other surgeons with the lipedema surgery is they would do a little, because of the volume, you do a little bit on each leg or arm so that you're symmetric. But I find because of the lymphedema approach, we use a tourniquet where we can do more at a time. The patient's going to sleep, we just treat the whole leg. And then for a period of time, 6 weeks to 3 months, we'll do the other leg. So you only have a short period where you're lopsided. And maybe because we're dealing with lymphedema patients where most of them are lopsided, so we are used to managing that expectation and how they feel about being lopsided. And also I feel that personally, I would like one leg to hurt at a time rather than both legs hurting at the same time. So that's how we do it. So we go through the surgery, what it involved. We make sure we got the garments ready. And then we usually have a second consultation, give them time to think about it and plan the surgery accordingly. So that's how we get them ready. Sometimes we need a third consultation if they're not getting it. Yeah.
Yeah. And what's the time frame generally between that first consultation until surgery?
So we usually we're booking ahead 3 to 6 months ahead because for here this situation we have actually most of the time we're planning 2 surgery. So we have to not just book one day. We have to make sure we can follow it up within 6 weeks to 3 months for the next
To
operation.
do the other leg. Yeah.
Yeah.
Do you have a lot of people traveling for surgery as well?
Yeah, I mean, I haven't looked into the lipedema, certainly the lymphedema. We are 40% are from interstate and New Zealand.
Wow. Okay.
Yeah.
And so lymphedema is more of a fluid issue. So you would be taking away fluid, not fat. Is that right?
No, most of it, when they are in the early stages with fluid, they just need garments and therapists.
Oh.
When they advance lymphedema, they actually get fatty deposits. So we do
Oh.
almost like lipedema when they advance. So that's why we're doing the same surgery.
Yeah, because they present very similarly. Yeah.
Yeah, but interestingly, there's no other colleague wants to do lymphedema liposuction. As you know, there's only, even for lipedema, there's a limited number in the country.
Yeah.
But lymphedema, we are the only one. So we're getting more interstate and New Zealand patients.
Wow. And that's surprising, seeing that my understanding is that lymphedema is recognized as a medical condition.
Yeah, I think it's actually it's a more intensive in terms of therapy and post-op. So the liposuction itself is not difficult, but so there are a lot of colleagues probably not investing into the whole setup. And the more we do, the more we are growing in terms of the therapy team and all this to support it. So it works pretty well.
And post-surgery, what do your patients expect with their care from you? Like you said, at the start, you'll have 2 or 3 appointments. You'll send them to whoever they need, like dietitians, nutritionists, psychologists. What about post-care?
Yeah, so post-care, so we try to operate early in the week so that we can manage it. We have therapists visiting them every day and then helping them with the garment change, because initially it's a bit sore.
Yeah.
We find lymphedema patients are not as sore as lipedema patients, because lipedema patients often, one of the symptoms of lipedema is actually soreness.
Yeah.
So we find that after surgery, they do seem to be a bit more sore, and they get supported by our therapists, and I see them in the hospital. If they're in a private health fund, we would perform the surgery at Macquarie, where we do acute hospital. We make sure they're stable for 2 days. Then we transfer them to a rehab hospital, Mount Wilga in Hornsby, where they have therapies over the weekends and experience therapy. Then we look after them pretty much for another week so that they going home confident. And then we see them 3 weeks, 6 weeks, 3 months, 6 months, 9 months, 12 months. And we make sure that surgical swelling goes down. In that period of time, the therapists will be helping them in terms of keep shrinking the garments, because the other thing that we'll get is some loose skin. So we want to use some surgical garments to help control the loose skin. And we find that we would say at the end of 12 months, there will be some loose skin. Most patients just live with some normal cosmetic garments or stockings. Probably 10% of patients would want to have some skin removed. Then we do mostly a thigh lift. Below the knees, amazingly, the skin seems to shrink very well. It looks very nice below the knee. It's just the thighs a bit wobbly normally. So you do get a little bit of loose skin after. But most people accept it. Others, you may want to have some skin removed.
Yeah. And you do the skin removal as well?
Yeah, sure.
Okay. Well, that's good because they got the one person. They don't have to go and source somebody else to do that side of their surgery. So that's really good.
Yeah, that's right. I mean, we just performed a surgery today, this week. A lady who had a lot of weight loss, and she was from another surgeon. So they did a lot of different types of skin excision in the tummy, in the breast, everything. But when it comes to the legs, even though they lost a lot of weight, they still got a lot of fat to be sucked out. And the surgeon decided they're not set up to do large volume liposuction. So she sent the patient across to do the liposuction.
Yeah.
So we've done the whole leg this week. On Monday on the right leg, we're going to do the left leg in 6-8 weeks time. Then the patient will go back to the surgeon to see if if they want to do a thigh lift later. Yeah.
Well, that's a lot of surgery, isn't it?
Yeah.
Yeah.
Yeah, that's right.
And you did mention compression. So you do compression beforehand and after?
Only compression. The one before has really helped them to get used to wearing garments, because we want them to get used to it. Otherwise, after surgery, it would find it a bit difficult. Some patients find it difficult to wear a garment, then it defeats the purpose to an extent.
Yeah.
We want to support the skin. So we just sort of get them used to it, and also getting them to know the therapist to work with them for that purpose, for that reason.
Yeah, because that relationship with the patient and their therapist is a very important one when you have lipedema or lymphedema. You become very close with them.
That's right. Yeah, that's right. And they spend a lot more time than I do with them, so they get to know each other, they support them, and any other issue. Yeah, and then they will talk to me if there's any concerns.
Yeah, that's awesome. I think we were speaking to another surgeon, and they're explaining to us the importance of compression post-surgery is because you've gone in there and you've created this plane where you've taken all the fat out, and so the compression helps with that all coming back together and stitching back together.
Otherwise there's
and also helps the skin to stick back. So the way I explain to patients is, when you do liposuction, if you cut a piece of skin out after liposuction, it looks like an empty honeycomb, and then the garment collapses it like a wine rack. So you collapse it, and then it sticks together. So then you can minimize any loose skin. And as I said, I've been amazed how nice the calves look. Below the knee, the skin really shrinks very well.
So I guess the skin is different on your lower leg than your upper leg. Like your inner thighs, it's like a lot softer skin, isn't it? Than on your shin.
So it feels that way.
Yeah.
And there seems to be a crease in the middle of your inner thigh. So if you lose weight, a lot of skin hangs over in that. Yeah.
I'm not sure if you asked this already, but do you do skin excision at all?
Yes.
Yeah, we use garment for 12 months to support the skin, and then we assess it at the end of 12 months if we need to do some skin removal.
Awesome. So whole leg,
at
a time, and then garment and rest 12 months, and then come back, see how your skin's going, and you tackle that if you need to.
That's
and you do arms as well?
Yeah, we do arms, and we haven't gone into the volume issue. So we do each leg because of the volume, that blood loss that may. So we want to control that, but we don't want patients to come back 4 times. So if the patients who wants the arm, then we will do one leg and one arm, and then we do the other leg and the other arm. So we're still doing 2 surgeries.
Yeah. Wow,
that's so good.
Yeah, that's so interesting. I'm trying to picture having one arm and one leg out of action at once. That'd be so. It would be so interesting looking at yourself in the mirror with one smaller arm and one smaller leg.
But as Professor Lam was saying, he predominantly works with lymphedema, and they're used to having one side.
That's true.
Yeah.
That's right.
Wow.
And very occasionally, because we're doing the patient lying flat on the back, so we're not able to suck anywhere in the buttock. So occasional patient wants to come back. The third operation is actually doing the buttock because we put them on the front, then we can suck. But we do both buttock at the same time.
Yeah. Be a bit hard to sit down, wouldn't it?
I was thinking the same thing. How interesting. Be on an angle. Oh, very cool. Oh, that's so interesting. It's so crazy how you all have a different approach, but even in your different approaches, like it's looking at the patient and what they need. So it's not like a standard thing. And so in terms of a successful surgical recovery for you, what are your recommendations for someone to really thrive during that recovery process after a surgery with you?
Well, we find that basically if you are really well informed, you know what to expect. That's one less issue after that. And then, of course, we're there all the time to look after them after surgery. As I was saying to Shell, we pretty much, I think we keep patients the longest in hospital. They're in the acute hospital for 2 days until the acute thing's over. Then we transfer them to a rehab hospital for garment support and wound support for 1 week, so that we wanted them to go home without any concerns, and they can pop back if they need to. And we see them 3 weeks, 6 weeks, 3 months, 6 months, 9 months, 12 months. And if we don't need to remove any skin, then that's it. And to make sure you achieve what you want, really.
Yeah. So I know that because I was talking to your office, I suppose, before we booked this appointment, and they alluded to your kind of process, the alert process. Do you want to talk a little bit about that methodology that you use?
Well, two things that we think that we're proud of. Firstly, the alert program, the center, is that we start off with the lymphedema, but we treating the lipedema patient pretty much the same with a one-stop shop, basically. So we have therapists there, we have physicians there, we have psychologists, nutritionists, and all that. So we want to look after the whole person, and we provide that full management for at least 12 months. And then in terms of surgery, we also do it differently because, firstly, as you say, there's different ways to skin a cat. But we come from the lymphedema side. As I alluded earlier, people always ask about the water jet. So we tried it on 2 or 3 patients. We haven't found any advantage over what we are doing. And the way that we use is Professor Bruson's method, Broson's methods from Sweden, where we put a tourniquet on the upper arm or the upper thigh. So we can actually increase the volume we suck out without any blood loss.
Wow.
So then we put compression on. After we've done that, then we can take the tourniquet off. Then we do the normal tumescent liposuction above that part. The average teaching is 2 hours, 2 liters, 2 liters. Then we can extend it to, I think, 8 liters. We've done, and for the whole leg, we have the whole system of lymphedema measurements. So we would measure, I think most legs are somewhere between 10 to 20 liters in terms of volume. 1 liter is 1 kilogram roughly.
Yeah.
So after a number of patients now, we can pretty much say to patients before surgery, your leg is, let's say, 15 liters. We will remove 30 to 35% of that for you.
Yeah, wow.
Which would equate to about 5 liters. If it's 20, we say what would be 3 times 2, it would be 6 or 7 liters. So we can actually inform the patient before we started how much we're going to get out.
And that helps with the expectations too. So I think that's
right.
One of the hardest things is what the patient is expecting and what the surgeon can do with their body. So that's great that you set those realistic expectations from the get-go.
Looking to expectations, how do you chat to your patients about their aesthetic goals?
Yeah, so we ask them. We ask them often, actually, when they come to the clinic. We have the questionnaire for them. What are their expectations? And as I said, we have the medical screen with the rehab specialist, and they go through that. And then the therapist also talks to them about it. And of course, I talk to them. And my consultation with them will give them a bit more realistic expectation how much we're going to remove and how we're going to do it. So pretty much we find it 30% is very safe from our point of view, sometimes 35% if we, of course, they tell us don't stop, keep going.
Yeah, we have this urgency that we just want it all out without understanding that fat is actually not a bad thing.
We need a certain amount of fat.
Yeah. In our brain,
That's right.
like we're diseased, get it out.
That's right.
So I'm just thinking about this, the skin excision. What does the wounds look like after? So say someone's had the full leg done with you, and I assume that they're just small wounds in various parts of the leg, like puncture wounds.
That little keyhole. Yeah.
That's right. Yeah, they're 5 millimeters cuts, and we have a number of them to try not suck across any potential lymphatics.
Sure.
So we have a number of circumferential ones, but they're so small. Takes about 6 weeks. You won't notice them.
Yeah.
And then we don't need to come back. We just treat it. We finish the whole leg. So
yeah. And so because you're not using fluid when you're recovering from that surgery, is there leaking of those wounds?
Only at the upper part, as I said, where the tourniquet was.
Yep.
You only leak 2 or 3 days, and then the wound dries up by the end of the week.
Yeah, minimal leaking. That's great. I remember when I got my surgeries and just the amount of fluid coming out of my legs, and they did warn me about it. Thank goodness they did, because I was like, whoop, that's real, very real. Yeah.
Yeah, we don't put that much fluid in.
Yeah, that makes sense that it wouldn't leak so much. So then after the skin excision, what do the wounds look like from the skin excision? Is it
the skin excision, we stitch it up, so it would just be a line.
a line? Yep.
It's just a longer one. There's a number of positions you can, depending on, everyone's got to be individualized, depending where the loose skin is. There's basically 3 positions. One is in the crease under your thighs, along the groin crease.
Mm-hmm.
Otherwise, you can make it vertical, so it goes from your crouch down to your knee on the inside or the outside.
Right.
Yeah.
Okay.
Depending where the loose skin is. Yeah.
Okay, and so that would be a conversation that you have with them, like
At the end of 12 months, yeah.
You would suggest that scar is going, and then is there often people that just go, whatever, Prof, I'll do whatever you want, or are they like, no, I'd prefer my scar to be here or there?
Yeah, as I said, it's individualized. So everyone, there will be people on this side or the other side, or they don't want anything done, or they worry about it. There are patients who just leave it to us, other patients who particularly want certain things. And it's our job to tell them, is it feasible? Is it advisable? And what we think is best for them.
Sure.
Yeah.
You mentioned that when they have surgery with you, they're in the rehab part of the hospital for about a week. What does a day look like for a patient in that rehab unit after they've had surgery for their lymphedema?
So they would have a shower, they change all the dressings and help them put the garment on. And then there's some help in terms of occupational therapies, walking, moving about, and training them to do the garment themselves so that they're comfortable and confident. Then they go home.
Yeah, excellent. Yeah, I'm just reflecting back on my experience in my recovery, and I think it would be so nice to be in a rehab place where you just, if you had any concerns or you're a bit anxious about your recovery, then there's that extra support, like geographically as well.
And the NLD comes to you, and the physio comes to you. You don't have to make separate appointments and go places, which is great.
Yeah, that's true.
Yeah, we find otherwise you don't want to ring up, or you have to pop in, or depending where you live, you're a lot more reassured in there, not having to worry about it at home. Yeah. Otherwise, your family become your nurses.
Well, yes, my mum was my carer and she was my nurse, and luckily she's really good at it, but the poor thing, I'm not the easiest patient.
I hope you pay her well.
I pay her in Nova Cuddles. When she comes over, I'm like, here's the baby gives you love. Prof, okay, so where can the lipedema community find you?
Well, we at Macquarie University Hospital, we've got websites and all sorts of those social media stuff. And there's a phone number they can ring. So the initial contact, then we send them out some forms to fill in, really about expectation and what they are looking for, and then we go through the process of assessment with the rehab specialist, medical assessment, the therapist, and I would say somewhere between 50 to 75% of patients happy with all that, and maybe a dietitian and a psychologist, and only probably about 25% actually go on to want to have surgery.
Wow.
Wow.
Yeah, I guess we are learning more and more the power of conservative management when done consistently. And,
Yeah.
I know that from the panel discussion at the Lymphedema Australia conference, the surgeons were all like, we're the last resort after everything else
That's
has
right.
been
Yeah.
done.
Yeah.
Yeah. Last resort.
I mean, quite often patient is really, because it's still a new thing, that they just needed to be reassured that they're normal, that they've got a condition that they can't do anything about, but they can manage it. And that's all they wanted.
Yes, that little bit of reassurance.
And especially from
Yeah.
a voice of authority too. You know what I mean?
Yeah.
It's completely different. Your friends telling you, but to actually go to a doctor and for them to reassure you,
True.
that's gold standard, that one.
That is.
That's right.
Yeah. Awesome. So we're going to put you on the spot here. Is there anything exciting we, as the lipedema community, should know about that would impact us that's coming up for you?
Yeah, not medically. I think with what you guys doing and the Lymphedema Australia and Dr. Mackie and other people, I think is really the diagnosis, the community, and lobbying the government to try and make the costs a bit better for you guys.
Yeah.
Yeah, so true. Yeah, the government. We were talking before about, writing to your local member, writing to the ministers and stuff. That stuff all creates traction, but it's slow, and
Yeah, that's right.
the power is in the numbers.
Yeah.
That's right. That's right. So, I mean, but it's increasing, and I certainly see it and I feel it, and the activity is great, and you guys doing a good job.
Thank you
Thank
very
you.
much. Well, the power of our podcast is in our guests. And, we're so grateful to be able to have specialists like yourself be gracious enough to come and talk about your expertise, because we're that link between the community and where they can access help, which is someone like you. And we thank you so much for coming on our podcast today.
No, it's my pleasure.
Wonderful. All right.
That's it.
That's it. Thank you so much.
Thank you
No,
so
that's it.
much, Professor.
Take care.
Bye.
Bye.
The Lipoedema Podcast 2025 is powered by Elegance Lymphatic Care. Lipedema and its symptoms vary from individual to individual. The opinions and advice voiced in this podcast are of a personal nature and used for educational purposes.
Please take away from this podcast what resonates with you, and please see your GP or preferred specialist for diagnosis and healthcare. We are Shelley and Tiana from the Lymphedema Podcast. Until our next episode, bye for now.